All right. Oh no, Maggie. Can you guys hear me? Hmm. Oh, you can. Huh. All right. Well, thank you for responding. On my screen, it's showing no volume coming out of the microphone audio levels. All right. So, let's begin then. All right. So we left off at the beginning of the blood vessels or the vasculature, and these blood vessels are organs. Oop, you guys can't see. Just a second. All right. So they're organs of the cardiovascular system. And they form a closed circuit that transports blood from the heart to either the tissues or the lungs and then back to the heart. Um, we say humans have a um, closed circulatory system because blood never leaves the circulatory system, never leaves the blood vessels. It remains in the blood vessels the whole time. Some animals have an open circulatory system, which is where there are chambers where blood can pool. Humans don't have that; it stays in the circulatory system the whole time. The exception to that is just some interesting trivia. Pregnant women at the placenta, which is an interface between mother and child, on the maternal side, there actually is um, a region where blood is able to pool so that the fetus or embryo is able to um, pull more nutrients from the mother's blood. So just interesting side note. The one exception to that fact that humans have a closed circulatory system is pregnant women at the placenta. Um, just always like pointing that out. Good. So the types of blood vessels. We have arteries, which you've all heard of. They carry blood away from the heart. Okay. And a lot of people think they always carry oxygenated blood. And that's true in the systemic circuit, but in the pulmonary circuit, they carry deoxygenated blood. So just one little exception there. Arterioles are basically small arteries. They receive blood from the arteries and they carry it to the capillaries. Um, they're basically smaller arteries with a thinner wall. It's kind of like when you are driving on a massive interstate with 8 lanes in each direction. You know, those are the arteries. In fact, that's the aorta. And then branching off of the aorta will be arteries, big highways, and then you can take an exit onto a small highway, which would be like the arteriole, and then you can take an exit off of the small highway down to surface streets where you can access restaurants and gas, and that would be the capillary, just as an analogy. So capillaries are the actual site of exchange of substances between the blood and the body cells. So when we are dumping off glucose and ions and whatever else the tissues might need, oxygen. We're doing it at the capillaries. We'll also pick up waste in the capillaries and we'll bring that back through the venules. And the venules, they receive blood from the capillaries and take it to the veins. Venules are basically smaller veins. And then the veins receive blood from the venules, carry that back to the atria. So here you can see a comparison of arteries on the left, veins on the right. And a couple things to take note of right away. This middle muscular layer is much thicker on the artery, and it's very thin on the vein. Okay. Another dead giveaway that we're looking at an artery on the left and a vein on the right is the presence of valves. Valves are only present in veins. And the reason for that is that blood in the arteries is under high pressure and it's being pumped forward with each beat of the heart. Blood in the veins is not really pushed back by the heart, and it's going to be pushed back by another number of other means we'll talk about in a second. But uh, it's a slower, lower pressure procedure moving blood through the veins. And so with these valves, we can prevent the backflow. All we have to do is move it forward a little bit, and then the valves prevent backflow, and then we'll move it forward again, and then there's another valve that prevents backflow. On the right over here, you can see a comparison of an artery on the bottom and a vein up top. The wall of the artery you can see is thicker, okay, than the wall of the vein. You can also see, of course, that the vein is much larger than the artery, and that's true. That's something we can't see in the cartoon to the left. Veins will be larger than arteries. All right, so angiogenesis is the process of forming new blood vessels, and it occurs in response to vascular endothelial growth factor, also called VEGF. Basically, when cells are hypoxic, meaning when cells in a tissue don't have enough oxygen, they're going to release the signaling molecule VEGF. And then the nearby vasculature, when it detects VEGF, will start growing in that direction. Will start growing new vessels in the direction of the cells that are releasing VEGF. All right. Good. So, yeah, we normally release VEGF in order to develop new blood vessels to areas that need oxygen, right? So that we can provide them with that oxygen. They weren't being served by blood vessels before. We're going to grow blood vessels in that direction now so that we can provide them with oxygen. But it's also secreted by tumors, which use VEGF to nourish themselves. Tumors, when they develop their own vasculature, when they develop their own blood supply, can become much more dangerous. One, because they're able to steal blood and nutrients from other nearby tissues, and then two, because it increases the risk of metastasis or spread through the body, because it just takes one little cancer cell to slip into the bloodstream, and then it can move to a new part of the body. So one of the treatments for cancer includes anti-angiogenesis drugs, and they can be used to stop the development of new blood vessels and then try to starve the tumor. So the arteries, as we said, are thick and well, their walls are thick, sorry, and very muscular. Okay, there are three layers or tunics in the artery. You've got the tunica interna, also sometimes called the tunica intima in some textbooks. That's the innermost layer. The middle layer is the tunica media, which is composed of smooth muscle and elastic tissue, but as you can see, there's a lot of smooth muscle. And then the tunica externa, also called the adventitia, is the outer layer out here in white made up of connective tissue. Okay. So arteries, as we said, are going to transport blood under high pressure. Then they'll give rise to the smaller arterioles. Arterioles have a thinner wall than the arteries, but they've got the same three layers, the tunica interna, tunica media, tunica externa. They're just thinner, less smooth muscle in the tunica media. And then the walls of the middle and the outer layers, as we said, become thinner. Both arteries and arterioles can undergo vasoconstriction and vasodilation. Vasoconstriction is when the blood vessels, constrict or become smaller. That smooth muscle contracts and it's going to squeeze on the blood vessel to make it more narrow. You can, conversely, uh, relax the smooth muscle and cause vasodilation, which is where the blood vessel sort of enlarges, the lumen of the blood vessel enlarges. And so through vasodilation and vasoconstriction, you can control blood pressure. All right, so the arterioles are surrounded here by this circular smooth muscle, which when it contracts is going to squeeze on the blood vessel. Here you can see an arteriole giving rise to a capillary here. Okay, so the arteries feed into the arterioles, and then the arterioles feed into the capillaries. And we have this precapillary sphincter here, this ring of muscle. If you were to contract this muscle, you can actually shut off blood flow to the capillary. And if you do that, you're shunting blood away from this area and then further down the arteriole to other tissues. All right, so we do that, for instance, a lot in the skin. If you are hot, your face gets red because we are opening up these capillaries. We are sending a lot of blood to the surface of the skin because blood's hot and we can radiate that heat away. When it's cold, you turn pale because we have constricted this precapillary sphincter. We are shunting blood away from the skin. And in doing so, we keep our hot blood away from the surface of the skin and we don't radiate our heat away. You want to keep that hot, precious heat in your core. You don't want to send it out through the skin. All right, so capillaries are, of course, the smallest diameter of the blood vessels, of the different types of blood vessels. And they connect the arterioles to the venules. And they're really an extension of the inner lining of the arterioles and the venules. All of these are lined with, I should go back because this is important. All of these are lined with endothelium. Endothelium here is really simple squamous epithelium, but anyway, they're all lined with this endothelium. Endothelium is, and it has some important qualities. It's smooth for one, and so because it's smooth, platelets and thrombocytes won't readily stick to it, won't start the clot formation. Um, process because the inner lining is smooth. All right. Good, good, good. So they are semi-permeable, the capillaries. There are, depending on which tissue you're in, there's sometimes gaps between the endothelial cells that'll let some big things get through. Um, and in the case of inflammation, we release cytokines, which increase the size of those gaps, make the capillaries more leaky. so that we can get white blood cells through those gaps between the endothelial cells. All right, so as we talked about earlier, the capillary blood flow is regulated by the precapillary sphincters, that smooth muscle ring we saw leading off to the capillary. All right, so as you can see here, we've got the endothelial cells and we've got some gaps in between them. And some tissues are more leaky than others. The capillaries in the functional regions of the kidney are going to be very leaky. The gaps in the liver are very leaky because we need to get substances into the liver so we can, process those substances. The liver does a lot of our biochemistry, a lot of our metabolism happens in the liver. And then in the brain, you guys probably remember the blood-brain barrier. These gaps are going to be tiny in the brain. We don't want to let just anything through. All right. So you can kind of see the capillary arrangement here. They run in a network between the arteriole and the venule. Okay. It's kind of like web-like network. The arteriolar side is, of course, going to carry blood rich in oxygen, and the venular side is going to carry blood low in oxygen. Because in the capillary bed, in these capillaries, we are exchanging oxygen and giving that to the tissues, and we're picking up CO2. So the capillaries, as we said, exchange gases, nutrients, and metabolic byproducts between the blood and the tissue around the cells. So this is how exchange occurs. We've got diffusion, filtration, and osmosis. Diffusion we should all be familiar with. So lipid-soluble substances are going to diffuse through the cell membrane, through the endothelium. Water-soluble substances have to diffuse through channels and slits in the membrane. Then we have filtration, and this is where hydrostatic pressure forces molecules through the membrane. So what's hydrostatic pressure? Well, first of all, it's pressure. Hydro refers to water, and then the static, in this case, we'll say hydrostatic pressure is the pressure exerted by the blood on the wall of the capillary. It's the outward force, the outward pressure of the blood in the capillaries. Okay. It's derived from ventricular contraction, meaning when the ventricles contract, they drive blood pressure up. When they relax, blood pressure drops. We'll talk more about filtration in a second if that didn't make sense. Then we've got osmosis, which is where you've got an impermeable solute like plasma proteins that have to remain in the blood. They can't leave the blood. And they're going to draw water back into the capillaries, which is the opposite of filtration. Filtration is where hydrostatic pressure forces molecules and water also out of the blood. And then osmosis, osmotic pressure, is going to draw water out of the out of the tissues back into the capillaries. And so we can see capillary exchange here. On the left, we have the arteriolar side. On the right, we have the venular side. Okay. And you can see there's an outward hydrostatic pressure. And they've measured this to 35 millimeters mercury. 35 millimeters mercury. mmHg is what that means. It's just a unit of pressure. Like inches are a unit of distance, millimeters mercury is a unit of pressure. Hg is mercury. All right, and so the inward force is going to be the osmotic pressure. Okay, remember there are plasma proteins in the blood, and they are drawing water in through osmosis. So the osmotic pressure we've measured at 24 millimeters mercury. And so if you take these two numbers into consideration, you got an outward force of 35 millimeters mercury and an inward force of 24 millimeters mercury. You can just subtract those and you get a net outward pressure of 11 millimeters mercury, right? The difference between 35 and 24 is 11. So between these two, there's a net outward pressure of 11 millimeters mercury. Now, as we go down the capillary, okay, because there's a net outward pressure, the hydrostatic force is going to drop, right? As water flows out of the capillary and into the tissue, okay, um, the hydrostatic force will drop. Basically, volume and pressure are related, and as the blood volume drops because water is flowing out, the pressure will drop too. So we get down to the venular end, all right, and the osmotic pressure is roughly the same. It's pretty much the same as it was at the arteriolar end. They're both going to be, in this example, 24 millimeters mercury. However, the outward force has dropped to 16 millimeters mercury. So in this example now, there is a net inward pressure of 8 millimeters mercury. Okay? And so what that means is that at the arteriolar end of the capillary, we're going to see a lot of substances flowing out. Uh, Water, of course, we're going to see water flowing out. Um, well, let's keep it to water for just now. Well, we'll see a lot of water flow out. And at the um, venular end, we're going to see some water flow back in. Okay, some flow back in. Now, if the pressure, net outward pressure, is 11 millimeters mercury at the arteriolar end and it's 8 at the venular end, that means that some of the fluid, some of the water that flooded out of the capillary and into the tissue is not going to get picked up. If the outward at the start and the inward at the end were the same, then we would draw all of our fluid back into the bloodstream. That doesn't happen. That just doesn't happen. So what it means is we're going to be dropping off water into the tissue that we're not picking up. And if we continue to do that, we're going to get edema, which is a collection of fluid in the tissues. Can be pretty bad. Now, in the normal, healthy person, how do we deal with this? Well, we've got the lymphatic capillary here. And we'll talk about the lymphatic system next week, but it all starts here. The lymphatic capillaries pick up the fluid that's dropped off in the tissues. So the excess, the extra fluid that's dropped off in the tissues, some of that gets picked up by the capillaries and carried back to the heart. All right. So we were just talking about the exchange of fluids here, but since we've got the picture up, we are of course going to see substances like oxygen, which can diffuse across the barrier here. We're going to see that diffuse into the tissues readily. Glucose will be allowed to slip either through the cracks or through channels in the membrane. And then yeah, all of your substances will be allowed to slip through. Then we'll pick up wastes and we'll carry them through the capillary to the venule to the vein to get returned to the liver or the kidney. So venules, they're also microscopic vessels. They pick up after the capillaries. They pick up the blood from the capillaries. And they have much thinner walls, and that's because they have a lot less smooth muscle than the arterioles. All right. Here you can see the veins. They've got thinner walls than arteries. The tunica media is less developed, meaning there's less muscle, right? Less smooth muscle. And they carry blood under low pressure. they function, we could say, as blood reservoirs, uh, in that they fill with blood until it can be returned to the heart, and that we have these many. We should point out these many valves, flap-like valves in the veins. They prevent the backflow of blood. That'll be important in a second. So here you can look at the distribution of blood in the body. About 4 to 5% of it is found in the capillaries, 10 to 12% found in the systemic arteries, 8 to 11% is going to be found in the heart at any given time, 10 to 12% is going to be found in the lungs, and then go ahead and compare the systemic arteries over here to the systemic veins. 10 to 12 versus 60 to 70% of the blood will be found in either the small veins and venules or the large veins. And so for this reason, we can say veins are a blood reservoir. Um, they hold on to the blood until it can be returned to the heart. About 2/3 of all blood is in the veins and venules. All right, so here's some blood vessel disorders. Atherosclerosis is where we see cholesterol plaques form in the inner lining of the walls of the arteries. If I can go back a second to an artery, here we go. You're going to see those form either on or immediately under, probably immediately under the layer of the endothelium here. And when that happens, you get this sort of building bulge over time, and that's going to narrow the lumen of the artery. And so if a blood clot is traveling through the bloodstream and it comes upon this narrowed region, we can block blood flow totally. And if you block blood flow totally, whatever's downstream of here, that tissue's going to die. Um, yeah, that just whatever's downstream of here, the tissue's going to die. This is common in the arterioles as well, the arteries and the arterioles. Sorry, I thought I heard something strange. All right, and then good. So atherosclerosis, we can say it's a hardening of the arteries. It will make them less flexible, less able to expand and contract with the blood pressure. Um, but we see that development of the plaques, and that's going to lead to clotting issues. It's going to increase your risk for heart attack. Let's get back down here. An aneurysm is a bulge in the wall of an artery, which is formed when blood pressure dilates a weakened area of the vessel, and it can burst the wall of the artery. If I'm remembering correctly, that's what killed Albert Einstein. He had one aortic aneurysm in his abdomen, and they went in to repair it, and the uh, method they used to repair aortic aneurysms back then was to insert a wire mesh into the vessel and just force it to grow scar tissue, and just irritate the crap out of the aorta basically. And he said it was so painful that when he had another aortic aneurysm later, he just said, "Let me die." It's not an exact quote, but he chose to forego the surgery. Said, "I'm not doing that again." All right. Phlebitis is an inflammation of a vein. It's pretty common in varicose veins. You can see abnormal or irregular dilations in the superficial veins. So when you see those blotchy blue areas on people's legs when they get a little bit older, I'm in my 30s. I just spotted a region of varicose veins near my ankle. Um, yeah. Anyway, atherosclerosis, by the way, is super deadly. Um, Number one killer in the world. It's not. It's not guns. It's not auto accidents, although auto accidents are pretty big uh, in the U.S. Number one killer worldwide is not war. It's not famine. it's cardiovascular disease or coronary artery disease. Um, and so that's caused in most cases by atherosclerosis, which is going to, again, narrow the blood vessels. And if you narrow the blood vessels in the heart, that predisposes them for for blockages. And if you block blood flow in the heart, that causes myocardial infarction or heart attack and death of the heart tissue. All right. So blood pressure is the force that blood exerts against the inner walls of the blood vessel. The blood pressure circulates the blood. That is, it pushes the blood along its path. The term blood pressure most commonly refers to the pressure in the systemic arteries. We only scientists really measure the blood pressure in the veins, and it's not very interesting because it's usually pretty low. There's blood pressure throughout the entire vascular system, although again it's pretty low in the veins. The blood's going to move like everything else from areas of higher pressure to lower pressure. So you guys are probably already familiar with blood pressure. Everyone as a child has sat in one of those machines at Kroger and checked it out. You get two numbers. You get your systolic and your diastolic. Top number is uh, top number is systolic, right? Yeah. Yeah, systolic. I haven't had my blood pressure done in a while. I started getting confused. Anyway, bottom number is diastolic. And of course, we know that systole refers to contraction of the heart. So when the heart is contracting, that's the pressure that it generates is the systolic pressure. And when the heart is relaxing, basically when the ventricles, we should say that when the ventricles are relaxing, uh, that's diastole. And the pressure at diastole is the diastolic pressure. Okay. So the systolic pressure is the maximum pressure that can be reached during ventricular contraction, and then diastolic pressure is the minimum pressure left before the next contraction. And so they give you those two numbers. What was your maximum pressure, basically, the systolic, and what was your minimum blood pressure, the diastolic? Now, the pulse pressure is the difference between these two numbers, so you can subtract the diastolic from the systolic to get your pulse pressure. The mean arterial pressure is the average pressure in the arterial system, and it represents the average force that drives the blood to the tissues. You can calculate it as the diastolic pressure plus 1/3 of the pulse pressure. All right. And so let's pull this up. Okay. If you have normal blood pressure is 120/80. So if we have a diastolic pressure, um, okay, of 80, and we add to that 1/3 of the pulse pressure, so that's the difference between 120 and 80. That's 40. 1/3 of 40 divided by 3. Uh, okay. And then we add back to that. Yes, so we got 93.333 is the mean arterial pressure in the in a normal individual. Now, there's another way to calculate this that I prefer better, and that's 2 times the diastolic, which would be 80 times 2. Oops, let's close this out. Which would be 80 times 2. Okay. Plus the systolic, okay, divided by 3, which gives us the same number, but it's just easier for me to work out in my head. All right, and I can write that for you here. Let's do insert new text box. plus. Okay, now it's frozen. That's not good. All right, 2 times. Come on now. 2 times the diastolic divide. Plus the systolic, and then all of that divided by 3. And here you're taking the literal average, right? Oh, I should explain why this works. The reason it works is because diastole lasts twice as long as systole. Okay, so diastole, again, it lasts twice as long as systole. So if we want to take an average of these two, we can't just add the diastolic pressure and the systolic pressure. Um, we need 2 times the diastolic because it lasts twice as long. Add to that the systolic pressure and then divide the whole thing by 3. Gives you the same number as this other equation. This one right here is just easier for me to work out in my head and remember as well. So the blood pressure, again, is stated as the fraction systolic over diastolic pressure. You've got in the average individual 120 over 80. They always say this is the average number. I mean, it is. A lot of people run at 120 over 80, but 120 over 80 is also the upper limit of normal. 121 over 81 would be, moderately high blood pressure. Yeah, that's the next step up. So, yeah. And as we said before, blood pressure is stated in units of millimeters mercury. Now, where do we get this name? And that's the pressure required to push mercury up a little glass tube 1 millimeter, right? So, if you really cared, just like a calories the unit needed to raise, I think it's a liter of water by 1 degree Celsius. You know, what's a horsepower? It's a power roughly equivalent to a horse raising some object. This is just a unit of pressure. That's what it is. Unit of pressure. That's all we really care about. Just like inches are units of distance, liters are units of volume. So this individual here is using a device. A lot of people call it a cuff or blood pressure cuff. It's got a cool scientific name. It's one of my favorite words in all of anatomy and physiology, and that's sphygmomanometer. Yes, that's right. Sphygmomanometer is the proper name for the blood pressure cuff. And now you can go home and impress your friends and family with your ability to pronounce and remember and maybe even spell this strange word. It's one of my favorite words, sphygmomanometer. Anyway, that's the name for the blood pressure cuff. And what we do is we line it up with the brachial vein, and then we're going to inflate it until it, not vein, sorry, artery. And we're going to inflate it until we compress the brachial artery. Then we release pressure. Okay, you see they turn this little knob on the air control valve. They turn that, and we're going to release pressure until you're listening with a stethoscope here, by the way, until you hear a heartbeat. When you hear a heartbeat, oh, hold on, sorry. All right, so we, yes, release pressure until the artery is able to open again. When that happens, we can hear the pulsatile heartbeat. Okay. Then, as we continue to release pressure, when we stop hearing the heartbeat, blood is flowing through normally. Okay. The first sound we hear when the heartbeat comes, when we're able to hear it, Okay, that's going to be the systolic pressure. Whatever the pressure reading is when you can hear the heartbeat, that's the systolic pressure. And whatever pressure it's at when the heartbeat disappears, that's going to be your diastolic pressure. All right, so here you can see a chart of the systolic and the diastolic pressure as we move from the aorta down to the vena cava, from the largest artery, which leaves the left side of the heart, to the largest veins, which return to the right side of the heart. All right, so in the aorta, blood pressure is highest because we're right outside the ventricles at that point. The systolic pressure is going to be much higher than the diastolic pressure. As we continue to move through the large arteries into the small arteries, you can see this gap between them is going to shrink, as is the total pressure. And then we move down into the arterioles, and then the capillaries as well. And once we reach the capillaries, the difference between systolic and diastolic pressure is gone. All right, there's just one blood pressure now. And following the capillaries, blood is returned to the venules, then the small veins, the large veins, and the vena cava. And you can see through the whole thing, the blood pressure is dropping. Okay. Um, uh, if you were to ask why, the biggest reason really is resistance. So as blood flows through the aorta and the large arteries, there's not much resistance. But once we start branching off into the small arteries, the arterioles, the capillaries, each time we branch into a smaller and smaller blood vessel, we're going to generate a lot of resistance to the incoming blood, and then that just slows the whole thing down until we've just got one blood pressure that slowly flows on its way back to the heart. You can see here this red line, which is pulsatile. It's indicating that the blood pressure pulses in the arteries with each contraction. All right, so these are the regions where you can most easily detect a pulse. The two most common ones are the carotid artery. I'm sorry, the carotid artery up here. That's next to the neck where you place your fingers there. Now, if you're a healthcare provider, most patients are not going to be super pumped about you shoving your fingers into their throat. So you should probably get good at taking radial artery pulses. I have been practicing and I am just okay at it. There are lots of people though that are quite accomplished at taking radial artery pulses. Um, yeah, you can also commonly take them from the brachial artery. Could take it from the femoral, although a lot of patients won't want you doing that. All right. Uh, So here's some factors that influence blood pressure. You've got blood volume increases. We said that volume and pressure are related. So as blood volume increases, blood pressure will increase. Think about it this way. You've got a balloon and you're blowing air into a balloon. Okay. As you push more air into the balloon, the volume inside the balloon increases, but so does the pressure, right? If you open the balloon up and let all that air out, the air volume decreases and so does the pressure, right? Now that you've let all the air out, you've got a limp little balloon with no pressure in there whatsoever, right? All right, so heart rate increases are also going to increase blood pressure because heart rate increase the volume of blood flowing through the capillaries, right? We're pushing more blood, not capillaries, through the arteries. We're pushing more blood through the arteries, so we're increasing the volume that flows through. Stroke volume increases. Now, this may sound like it's the same thing I just said, but when we talk about stroke volume, that's the volume of blood pumped with each heartbeat. All right, so you can increase the volume of blood that flows by increasing the number of heartbeats. You can also increase the volume that flows by increasing how much moves with each heartbeat. And you can do this by, well, you can dilate the large arteries. You can also make the heart more efficient. There are drugs that can do that. There are other stimuli that can increase the stroke volume. And so if we increase the volume that gets pushed forward, that's going to increase the pressure. You can increase the pressure by increasing the resistance. All right, so if you are preventing the forward flow of blood, you could also increase the blood pressure. And then you can increase blood viscosity. So what's viscosity? That's kind of the thickness of the blood. The better hydrated you are, the thinner your blood will be. If you're dehydrated, your blood will become thicker just because there's less water in it. And the more viscous your blood is, the less water there is in it, the higher your blood pressure will be. Now, I should say that works especially if you are overproducing either formed elements or plasma proteins. All right, so the stroke volume, again, that's the volume of blood that enters the arteries with each ventricular contraction. How much blood is pumped out of the heart with each beat? Bump, bump. How much blood was pumped? Your cardiac output is the volume of blood sent out of the ventricle each minute. Okay? And so you can get this by multiplying your stroke volume by the number of beats. So if you know the stroke volume, multiply that by the heart rate, and that's going to give you your cardiac output. So the average individual pumps about 70 milliliters of blood per beat. And then about 72 beats per minute, that's average heart rate. That's going to give us 5,040 milliliters per minute, or we typically just say 5 liters per minute is the average cardiac output. By the way, 5,000 milliliters is the same thing as 5 liters, so we just say 5 liters is the normal cardiac output. So blood pressure is going to vary with your cardiac output. Increases in either the stroke volume or the heart rate can increase the cardiac output, which will increase the blood pressure. All right, so the blood volume is the sum of volumes of plasma and formed elements. It's going to vary with age, body size, gender, but it's usually about 5 liters for adults. Okay, remember the cardiac output was also 5 liters. So every hour, we pump essentially all of our blood through the body. I'm sorry, every minute, not not hour. All right, so 8% of our body weight is the blood volume. Blood pressure is going to be directly proportional to blood volume. We said as we increase the volume, we're going to increase the pressure. And any factors that change the blood volume can also change the blood pressure. So, for example, a decreased blood volume due to either hemorrhage, that's bleeding out. So, due to a hemorrhage, will decrease the blood pressure. We mentioned viscosity earlier. So, if you're losing fluid from the blood, that's going to make the blood more viscous. Increasing the viscosity increases your blood pressure, but losing fluid from the blood also decreases blood pressure. All right, so the peripheral resistance, this is the friction between the blood and the walls of the vessels. There is a little bit of friction. The blood pressure has to overcome the peripheral resistance in order to flow. Now, normally we don't have a problem with that. Factors that change the peripheral resistance also change the blood pressure. So vasoconstriction, which we see in arteries and arterioles, can increase the peripheral resistance, and that's going to increase the blood pressure. When the blood is pumped out of the ventricles, the arteries swell up. That is, they expand, and then the rapid elastic recoil, that's where they kind of come back to shape really quickly. They expand when the ventricles contract and push blood out, and then they come back to shape. That's called recoil. That's going to send the blood through the arteries. the arteries continuing to shrink back to their normal size is going to continue to put pressure on the blood and push it forward after the heart has contracted. So viscosity, mentioned earlier, it's the difficulty with which molecules of fluid flow past each other. In other words, how thick is your blood? The greater the viscosity, the greater the resistance to blood flow. Blood cells and blood plasma proteins are going to increase the viscosity of the blood. Um, so the greater the resistance to flow, the greater the force necessary to move the blood, and then the greater the blood pressure becomes. So anything that's going to alter the concentrations of blood cells or plasma proteins will also alter the blood viscosity. So in the case of anemia, that's going to lower the concentration of blood cells. Lowering the concentration of blood cells will lower the viscosity and in turn lower the blood pressure. All right, so control of blood pressure is determined by the cardiac output and the peripheral resistance. Maintaining the blood pressure requires the regulation of both of these things. Okay, and so in this diagram, you can see here normal blood pressure is under 120 over 80. As we said, 120 over 80 is the upper limit of normal. Uh, all right, so if the blood pressure is too high, that's going to stimulate the baroreceptors in the aorta and the carotid sinus, okay, which stimulates the autonomic nervous system. I'm going to stimulate the control centers in the brainstem and the hypothalamus, the medulla oblongata and the hypothalamus. And that's going to cause the smooth muscle and arteries to relax, okay? And it's going to slow the heart rate. Slowing the heart rate decreases the cardiac output, which decreases the blood pressure. Dilating the blood vessels will decrease the peripheral resistance, which also decreases the blood pressure. And then our blood pressure returns to normal. Now, let's say we keep going and it drops too low. We detect these again with the baroreceptors, and we stimulate again the same control centers in the medulla oblongata and the hypothalamus. This time we're going to constrict the blood vessel, which increases peripheral resistance and increases the blood pressure. We're also going to increase the heart rate, which is going to increase the cardiac output and increase the blood pressure. All right, so let's see. All right, I feel like this is a good place to stop. We covered a lot of information today. Um, Tuesday we'll finish this up, and we'll discuss some of the we'll discuss the layout of the veins and the arteries throughout the body. And then we'll move into the lymphatic system and finish that up next Thursday. Okay? Do we have any questions? All right, so people are tuning out. I'm going to take that as a no. um, all right. Oh, hey, Michelle, thanks for answering. Nope. All right, so I appreciate you guys tuning in today. If you have any questions later, you can always email me, and yeah, I'm happy to discuss these things. All right, so we'll see you Tuesday. Have a good weekend.